We had to make sure that we had the right team with the right enthusiasm. We have a vice president of clinical operations, and then we use our nursing informatics teams in the hospital itself, and then the vice president for nursing informatics. They're heavy drivers of this because they're also workflow experts, so we work with them. But I think there's a bit of a unique challenge if you are doing this within a health system with more than 2 or 3 hospitals. So our 12 hospitals are geographically not necessarily near each other. A few are, but the others are kind of remote from one another. And what happens over time is that everyone develops their own culture, right? To the point that some hospitals have care models that differ a bit from other hospitals, or if we acquired that hospital where things stayed in place that were unique to that facility. But once you start centralizing and you serve an entire system through a centralized platform so that, somebody who's sitting in a facility in Richmond is advising somebody in Charlottesville, Virginia, or giving virtual support in Virginia, you need to be structured the same way. And so we had to work on standardization of all 12 of our hospitals so that we had similar models and similar ways of doing things and similar ways to document before we could really standardize this new thing. And that is an ongoing effort. And that is, paramount because over time, more and more things will become centralized and move out of the facility. And it needs to work every time in every facility that we support. So that for us was a challenge. And I know that we'll talk about this more, but how we actually began was with our frontline staff, having conversations with them, using our shared governance structure. We realized that every time we make a change, we can't go, to 14,000 nurses and ask them what they think. But what we can do is work together to set a set of core principles around this change management. And so we worked with our nursing teams, began by having our nurses identify who actually walks into the room today. I felt really good about myself. I could think of 29 different providers or people that walked into a patient room. But once we asked our nurses, we found more than 200 different people that could walk into a patient room, from a dietary tech to a pharmacy tech to, the person with the therapy dog. We listed them all. And when we had a realistic look at that and said, that's way too many people. This isn't a healing environment. We need to prioritize that. Let's talk about how we create a healing environment while preserving those core principles that we value as Sentara nurses, right? We wanted to maintain or improve experience. We want to maintain or improve safety. If we do this, it has to improve nurse well-being. So we made a long list of those core principles, and that's what we all agreed on across all of our different hospitals who are all working on standardization, and that's the core principle set that we follow. We then also created a list of hard stops, things that we would agree on we were not going to do. And one of those was not to change our nursing ratios, our nurse to patient ratio, and to keep that the same. And then we had several others, right? Limitations of the platform, or if it didn't meet the needs of the organization. And so once we built that core set of principles and we could all agree on it, it was easier to move through change and have everyone feel confident that we were doing that in the right way, as long as we were adhering to the core principles that we set together. So that's the work we did around culture.